Thank you, everybody, for joining us. Welcome. My name is Gabi Conacher, and I am president of Wishes for Elliot and help run the Deep Connections project, which is a part of our foundation, but really is a collaborative between ourselves and about 25 other patient advocacy groups working together to support DEE families, in particular those who have children who are pretty severely affected. So really glad you can join us, whether you're watching live or the recording. We are recording this session, and the only ones who are on video and speaking are the panelists. So if people who are listening in have questions, feel free to drop them into the Q&A in the chat, and we will definitely get to those. So as many of you may know, October 23rd was SUDEP Awareness Day. And in honor of that, this month we have our series on SUDEP that we're doing. The first one was on kind of the research and the what do we know about SUDEP. And today we're focusing in more on what can we do. And we've got a great panel with us today to share. But what I'm going to do is first I'm going to introduce Jill Paradise, who is a mother, and she has very generously agreed to share her story with us today. So Jill, I'm going to pass it off to you.
Hi. Yep, that's my baby. That's Quinn. I'll just start from the beginning. When she was a year and a half old, she had 2 seizures in one day, and they just chalked up. She'd been really sick, and they chalked it up to dehydration. And we're like, okay, and nothing else for 7 years. So summer of 2017, July the 2nd, I remember the days, she had another 2 seizures in one day, and we took her to the emergency room twice, and they just went ahead and they couldn't figure out what was wrong. So they just diagnosed her with epilepsy and said, we're going to put her on Keppra. And we're like, okay, and she'll probably grow out of it. Don't worry about it. We didn't even see a neurologist in the hospital that day. They just did phone somebody in because it was a holiday weekend. And so we saw a neurologist a couple weeks later, and they're like, oh, this is so no big deal. She'll grow out of it. Just, yeah. And all I could think about is, okay, if she's going to grow out of this, and then it's not going to affect her whole life, because that's all I can think about. And I also was worried that this was a pre-existing condition. I was really scared because the political climate we were in that summer was like, we're going to repeal Obamacare. And, you know, this is a pre-existing condition. And I was terrified to tell anybody that Quinn had been diagnosed with epilepsy, because I didn't want that to be stigmatized with her or sticking to her. So we didn't say anything. We didn't say anything to her teachers. We didn't say anything to anybody but our parents. And so 2017, she just flows right on through. Summer of 2018, we go in. So it's been a year and a month, August 1st of 2018, and go in and see a new neurologist. And she's like, she's great. Let's talk about weaning her off the medicine. And I'm ecstatic. I'm like, okay, at the end of the school year of 2019. So that's great. 3 weeks later, she has a seizure in the middle of the night. I happened to witness it. And this was August 21st of 2018. So that was 3 weeks. And she had it. I called the doctor the next day. They never called me back. And so I finally called 4 times. I think it was pediatric. Let's see. It's all children's in St. Pete, Florida, and they're part of Johns Hopkins, but never called me back. And I finally called the 4th time 24 hours later, and he said, I'm not hanging up until I talk to a doctor, and this seems scary that she had one in the middle of the night. Well, how's she seem? And I'm like, well, she seems okay. And she didn't have more than one. She only had the one, and she'd always had 2 in a 24-hour time period. So they're like, well, just keep an eye on her and let us know if anything changes. And okay. So I'm so nervous that we sleep with her for the next 5 weeks, because I'm just worried that she has one in the middle of the night. September 29th, my sister got married. That's where this picture was taken. And we went back to my hometown and my daughter was the flower girl in her wedding, and we had a great weekend. She had so much fun. Always had her medicine. We took it every single day. My alarm went off on my phone twice a day. Took it. We came home September 30th. 3 days later, that was Sunday night. 3 days later, we went in to wake her up on Wednesday morning, and she was gone. She
Take your time.
we did CPR. We did everything. But she was already gone, I think. I was screaming, and my husband was screaming, and my 5-year-old ran in. We're on the phone with 911, and I don't know, the whole morning's just a blur. And suffice to say, it was the worst moment of my whole life. That was 2 years ago and 4 weeks today. Wednesdays are always hard for me. I don't know, she had a seizure in the middle of the night and just turned everything off, or if she had a seizure and flipped over on her stomach and suffocated in her bed. I don't know, and I'll never know. But the way we found her leads me to believe that she suffocated. She was face down, and had I known anything, or had we had no idea. We went in to see the doctor, because in the hospital, the ambulance took her to the hospital, and we came, and they're like, there was nothing we could do. So we just laid there with her baby, and she was gone. The next day, we did see her doctor, and her doctor's like, well, we think she died of SUDEP. And I'm like, what's SUDEP? I don't even know what that is. My husband and I are both like, and she explained to me, and then she's like, well, there's a NASA North American SUDEP research. And I was like, so I get online and start obsessing with all of that, and I'm still, she didn't tell us. She hadn't told us, and neither the other neurologist that we went to. Sorry, my dog's chewing on something. She just was like, I'm sorry. And I'm just like, how we now see other doctors, because I have a 7-year-old now. She was 5 at the time, but I've taken her to see a neurologist as well. But I told him doctors need to take their doctor hats off and put their parent caps on, and parents, and what they would do if they were in this situation, if they were in the parent situation. And we need to know, all parents need to be shared all the facts. We need to make our own decisions. Doctors can't withhold that information, thinking that they don't want to worry us. We didn't want you to worry. Your daughter was at the lowest risk. Well, she's gone. She was at the lowest risk, but she's still gone. So I should have known. And I have to live with that every day. I don't know if her death was preventable, or if it's, I'll never know. And my husband won't. And I don't sleep at night. I'm so terrified for my other children. And that's probably never going to change. My 7-year-old's been sleeping with us since. She's terrified. Some of Quinn's friends are terrified because I'm like, you don't have to worry. You didn't have this. It's not your family. I have since had another child and I'm terrified for him, but we had love to give, and but we're seeing another doctor just to get him examined as well. Seeing the doctor we took our younger doctor to. I just have to implore doctors to give parents or caregivers all the information. I don't care if it's scary. I don't care if the chances are slim to none. They said Quinn was going to, oh, she'll grow out of it. She's one of those, she'll just grow out of it. She'll grow out of it. She'll grow out of it. We've seen, I probably have seen 5 pediatric neurologists over the course of both of my girls' lives, and not one had ever mentioned SUDEP. I had to mention it to the 5th one when we saw him because Quinn had already passed away. So I just want to implore doctors to inform everyone. That's it.
Jill, thank you so much for being willing to open up that wound and share with us. We know this is something that you live with every minute of every day, and we're really sorry this happened to you. And our goal is to try to help families learn more about this and work with clinicians and doctors to make sure that this is something that is spoken about, and shouldn't be on the shouldn't be on us as parents who dealing with really with kids to have to research and find out. We need them to help us with that.
I agree. I tell parents that I meet that have children with epilepsy, I'm like, just ask your doctor about SUDEP, because I'm not a doctor, so I can't tell you everything. I tell them, if they ask me a few questions, I tell them what I know, and I tell them my daughter passed away from it. You have to be informed. But I would say at least 90% of the parents I've come in contact with have no idea that have children with epilepsy, have no idea that SUDEP is out. That SUDEP, they're like, what's that?
Yeah.
So it's just.
Yeah, it shouldn't be that way.
No.
It really shouldn't. So, well, really appreciate you coming and sharing how terrifying and horrible this is. And we appreciate how brave you are and for sharing and being raw about, this is the 2-year anniversary, and it's incredibly painful forever. Loss doesn't go away, and it rocks the community. And so
she touched so many lives. I still have people tell me how amazing. She was only 8. She was.
Yeah.
Sorry.
No, this is it. That's what it is. It's not, you don't have to hide anything here, but thank you for stepping up and being an advocate and speaking out, because that's the only way things change. So we really appreciate you, Jill. And I think it's a good segue to bring in Dr. Bill Gaillard, excuse me, who is joining us today with several hats. He is the chief of the divisions of child neurology and of epilepsy and neurophysiology, as well as the director of the comprehensive pediatric epilepsy program at Children's National Medical Center here in DC. Full disclosure, he is my child's neurologist. I will put that out there, which is why we love him. And he's also the current president of the American Epilepsy Society. We also have Elizabeth Donner. She's a neurologist and epileptologist, and also a project director at the Research Institute at Sick Kids up in Canada. And we have Tom Stanton, who's executive director of the Danny Did Foundation and Danny's uncle. So with that, Dr. Guyard, I'm going to pull up these slides for you to, let's see, I think I just closed it 1 second, to take us through.
Yeah, while you're doing that, I just wanted to thank Jill very much for joining us today. There's nothing more horrible than losing a child. And the picture is beautiful, just beautiful. And our heart hurts her. So I think that's a very appropriate introduction. I'm afraid I'm going to be one of the more staid and boring people. I'm really here to talk about the American Epilepsy Society position statement on SUDEP counseling. And my comments will be brief because this is a very brief document. Next slide, please. So this is a position statement, and a position statement is not a rigorous review of the literature. It is not a guideline which is based on a review of the literature. It is a statement that is designed to guide practice based on our opinions and views for how practice should be conducted. So it doesn't carry the weight of an official guideline, but we felt it was important to put this out, especially when Cameron Bryce had died. We were working on this, but this is when this was what was made public. And this comes to the AES Practice Management Committee in 2019, which is designed for reviewing practice and making suggestions and recommendations for practice for care for epilepsy. And this really recognizes a lot of the work that many people have done, especially Dr. Donner, in recognizing families' wish to be informed regarding mortality and SUDEP. And they wish to be informed at the beginning of their care, not at the end of their care. So this was a recognition of that need that many of my colleagues do not pursue, as you have heard very strikingly today. This encourages physicians, neurologists, and epileptologists to counsel families and provide some guidance for discussion that is based, it should be evidence-based approach, but it also recognizes that each approach needs to be individualized for the physician, for the family, and what the circumstances are for that child. So it doesn't dictate what you do. It encourages people and provides suggestions for that. So it is important, at least from our point of view, that this be as much evidence-based as possible. And as you all know, there is very little evidence, and there needs to be far more research to inform what we do so we can help families and prevent this tragic occurrence. So this is based predominantly, I put in 2027. So this is a forward-looking document. It is based on the 2017 practice guideline summary from the AAN. And that is, we recognize that was already beginning to be outdated. It provides the standard definition of SUDEP. It discusses the incidence of SUDEP, which was based on older data. It did recognize some of the more recent data on pediatric SUDEP that had just been published by Dr. Donner. And it also outlines what is known about risks, again, based off of the AAN guideline. This was not a review that we had done. Next slide, please. So there is a brief consideration about when to consider having this discussion. And this is mostly based on a sense for what those risks are. So for those patients with generalized convulsive seizures, those that are nocturnal, especially patients with Dravet where the mortality rate is 20% by the age of 18, poor adherence to medications, when families are obviously concerned. I find out everybody's concerned, and you got to raise it early on, and also new onset epilepsy. So these are the recommendations for especially when to consider, although in my view, this is something that you have when you first meet a patient, when you're first discussing the new diagnosis of epilepsy, and it's raised at other times as well when you need to. They talk a little bit about the approach, and again, emphasizing this should be tailored to the individual and a general sense for what to say, to including what SUDEP is, who is at risk, what can be done, and what the future holds. And clearly what we have to say and what we counsel and what we know is going to be based on future information that comes in through research and activity. It then closes by listing some resources that provide additional information and strategies for counseling families and again recognizes this is a personal decision that has to be tailored by the individual physician and the patients for whom they're caring. So this is just an acknowledgement that this is that physicians are really don't do this discussion often enough. It encourages people to do so. It gives them some of the materials and information upon which to have that conversation, and recognizes its importance. And that's it.
That's really important, and we appreciate that that guidance, not guidelines, but recommendations is really adhered to. Do you know if, I have a quick question, do you know, is this something that gets covered in training? For
well, it does at my institution. I mean, it's hard to know. I mean, the reason why do people not discuss this, and there are a myriad of reasons. I think they're mostly fallacious. And I just create the time to have the discussion whenever I see someone for the first time.
Yeah.
I confess there are people I've cared for many, many years, and I probably haven't had this discussion because I've changed my practice over the last couple of years. I try and bring it up when I think it's relevant, but I discuss this whenever I see a new patient. Mm-hmm. And I find almost that half the patients I speak to have already looked this up on the internet. And it's their worst fear. If I don't address someone's worst fear, then I'm not doing my job.
Gabby, the AES, American Epilepsy Society, has a series of presentations for trainees that people who train neurologists and other types of doctors can use. And there is one on SUDEP.
Terrific. Okay.
So as an example, so we can't make people included in their training program, but professional associations have made that information available.
Okay. Start.
And it's also, there's at least a session generally at the AES meeting on this topic, and PAME is now linked every other year. So the information is available, and whether it sinks in and gets conveyed into practice, like anything else we do, has always been a very tough nut to crack.
Right.
But certainly there have been very strong efforts to make this information available and to encourage people to have these discussions.
Right. Terrific. Well, we can dig more into that. Dr. Donner, pass the floor to you.
Thank you. Gabby, are you able to see my slides?
Yep.
Great. Jill, thank you for your story. I hear those stories all the time because of the work I do, and it breaks my heart every time. Not the way it breaks yours, but it's also incredibly disheartening because, as Bill mentioned, I've been working in this area for a long time, and I know we're still not doing well enough. I work with people like Tom, who's there today as well, trying to advocate for people to talk about SUDEP, and that's what I'm going to talk to you about today. And while you were talking, I added a couple more slides, so I apologize if I talk too long, but that I thought kind of addressed some of the things you brought up. So I hope you find it helpful. So, well, if Jill's story wasn't enough for you, here's proof that doctors aren't very good at talking about SUDEP. So here are 6 studies, data from the UK. When I move my mouse, can you see my cursor?
We can.
Yes, thank you. So data from the UK, a study done on American and Canadian neurologists that I did along with Dan Friedman, and some from Europe and South America. And the green bars recognize how many neurologists speak to all or almost all of their patients with epilepsy about SUDEP. And you can see the green bars are pretty small. The red bars show how many speak to none. Some of this data is kind of old, from 2005, but some of it's pretty recent, only about 5 years old. And we know, in fact, and I recognize that I'm talking mainly to families today who have a child, maybe an adult child, but a child with a developmental epileptic encephalopathy. And so I'm including a little bit of specific data about child neurologists, because we know they usually at least start the journey of epilepsy with people with developmental epileptic encephalopathies. And this is data of ours that's under review right now for publication, where we actually had the opportunity working with the Child Neurology Society to ask specifically child neurologists whether they talk about SUDEP. Only 12% discuss it with pretty much more than 90%, so almost all, only 12%, and about 36% discuss it with at least half. So we know we're not very good about this. This is one of the slides I added, Jill, while you were talking, that I already had, but I hadn't put in the talk, because I've spent a lot of years thinking about why people aren't talking about SUDEP, and I think these are some of the reasons. And that's not an excuse, but if we can figure out the reasons, maybe we can figure out how to help people with it. Some of it is about knowledge, and that's where some of the work through AES with Bill's leadership works on trying to make sure providers know about SUDEP and their knowledge base is good. There's all this stuff that you were talking about, Jill, where people think that it's about patient comfort. They are taking a paternalistic, I know you're shaking your head, I'm just speaking right to you. They think they're kind of taking a paternalistic approach to how they practice medicine. These are some of the barriers that really, I'm going to show you just a little bit of data prove that this isn't accurate. One of the big ones down here, Bill, I know we've talked about this before, is physician comfort. We just have to get the doctors comfortable about talking about it. But the ethics are consistent, medical ethics are consistent with us talking to our patients about this. It's consistent with the principle of autonomy, which means that patients and their families should be able to make decisions about their own disease, and they can't do that unless they have all the facts. We enter into relationships with our patients as doctors under the assumption that we will tell the truth. And by withholding this information, we're not telling the whole truth. We're all familiar with the first do no harm, prevention of harm approach to medicine. We're all supposed to adhere to this. And by withholding information, we're probably not preventing harm in this case. There's also some interesting data to support the fact that hearing about scary things actually allows for a natural psychological adaptation and how people come around to understanding that there is risk associated with the disorder that they have. Furthermore, there's actually no evidence that any kind of catastrophic psychological harm will come to people from learning about risk associated with disease. And we accept that pretty well for things like obesity and high blood pressure and diabetes. So I think we need to accept it as well for epilepsy. We know that families want to know more about risk. As an example, a study that asked caregivers of people with epilepsy, so family caregivers, up to 94% were worried that the person they took care of with epilepsy may die of their epilepsy. My colleague Rajesh Ramachandran Nair did some qualitative studies with parents, asking them what they wanted to know about SUDEP, and they all wanted to know about SUDEP, and they all wanted to hear about it from their doctor. An interesting study looked at Google searches for the term SUDEP. From 2004 up till 2013, there was a 5,000% increase in that search term epilepsy SUDEP. People are looking this up. 34% of surveyed UK parents already knew about SUDEP. 91% of them wanted to know more about it. And then that North American SUDEP registry that you made mention of is some of the work that I'm involved in. And we had the opportunity to ask families after they'd lost someone how they felt about the information they knew about SUDEP. And about 73% of families wished it had been discussed with them. 17% were not sure, and 10% were actually satisfied that it was not discussed with them. So as people who work with families of children with epilepsy or work with people with epilepsy, we need to recognize there will be people that don't want this information. And that's why when Dr. Gaillard was talking about that document, it's on my desk, that's why I'm pointing to it, was talking about that document and mentioned that we need to tailor discussions to our audience, to the family or the person with epilepsy. We always have to keep that in mind. So why should we talk about it? Families want to know. Knowledge is power. Informed families make informed decisions. Honesty and trust are foundations of our relationship with our patients, and people already know about it. And healthcare providers are, I hope, the most reliable source for accurate information for families. I often say when I'm speaking to doctors about this, do you really want them to get their information from Google? I mean, if they're lucky, they'll go to a good site like Danny did, run by Tom Stanton, and they'll get good information. But we know they're as likely, unfortunately, Tom, to go to a bad site and get bad information. And so we are their best source as their healthcare provider, and that's why we should provide the data. When should we talk about SUDEP? Well, 37% of adults said they wanted to learn about it at the time of the epilepsy diagnosis. 24% said they want to hear about it when seizures are hard to control, difficult to control. And 28% said they want to hear about it at follow-up appointments, regardless of whether the seizures were controlled or not. And as I already mentioned, all parents of children reported that they wanted to know about SUDEP. So this is where practitioners need to tailor their information and get a sense of the people they're working with and how to share the information. What should we say? What should we actually be telling families about SUDEP? I think we should talk about what is the risk and how can the risk be modified. So what is the risk? The risk is about 1 in 1,000 people with epilepsy per year. So 1,000 people living with epilepsy for 1 year, 1 will die of SUDEP. The next year, another 1,000 people, 1 will die of SUDEP. This is highly, that's of everybody who has epilepsy, but this is highly variable based on things about the epilepsy. How frequent are the seizures and what other challenges they have in association with their epilepsy. So we know that there are certain things like more seizures and other developmental disabilities associated that probably increase risk. So in the developmental epileptic encephalopathies, for example, the risk is likely higher, although the studies are lacking. The best studied group, as far as the DEEs go, would be children with Dravet or people with Dravet syndrome. And in Dravet syndrome, it's probably about 9 per 1,000 per year. People with Dravet would die of SUDEP. When you look at groups with more rare developmental epileptic encephalopathies, like SCN8A, for example, there are not the type of studies where we can talk about the rate of SUDEP. There are just these studies that have reported, we knew 100 kids with SCN8A and this many of them died of SUDEP. So that's not really a very accurate way of coming up with rates of death, but in those kind of studies, up to 10% could die of SUDEP. So doctors should be talking to their families about the risk of SUDEP, and then they should be talking about how to modify that risk. So how do we modify SUDEP risk? Well, it's really about managing the epilepsy the best we can. And I know that that's not always very satisfying, but it's sometimes shocking to find out that people aren't doing everything they can to manage seizures. And so working on seizure reduction, particularly generalized tonic-clonic seizures or the big full body shaking seizures, that's the most important treatment goal to reduce SUDEP risk. And so when we face people who are reluctant to use treatments to reduce those type of seizures, we need to remind them that they're likely increasing the risk of SUDEP. So it's super important that people adhere to their treatments and that they try to work to identify triggers for seizures and avoid those seizure triggers. When possible, if people can use some sort of nocturnal listening device when people have nocturnal seizures or seizures at nighttime, that may help. But Jill, we don't necessarily know that, okay? It looks like in some cases that may help because there's a little bit of evidence that when people go to someone after they've had a seizure, they may be able to reduce that risk of SUDEP. But we also know of cases where people have died while they've been with another person. And really, really important, if medications aren't working to control seizures, people need to talk to their team needs to talk to them about what other ways they could control seizures. Is there a diet they could use? Is there surgery that they could be eligible for? Is there a device that might work? So how do we apply this to people living with a developmental epileptic encephalopathy? It's really the same, and this is the exact same slide, but I know we have to put it through that different lens, because I know in a lot of these children and adults, the seizures we will not be able to control the seizures, but we need to do our best to identify triggers, to figure out how monitoring may reduce the risk, and to consider other treatments besides medication. So I want to point out, and I know I'm speaking to families here, but I want to point out that there's a few tools that doctors can use to talk to families about SUDEP. And there's nothing to stop families from asking their doctors if they know about these tools. One of them is something called the SUDEP and seizure safety checklist. At this time, it's geared towards adults, but it's basically a checklist of conversation starters and items to discuss around safety and epilepsy. So everything from driving and taking baths to, are you taking your medication, and what are the barriers to taking medication? The Child Neurology Foundation has some really excellent documents that can be conversation starters between healthcare providers and families. And they have two different documents, one about understanding that a child's SUDEP risk is low, but it's still important to stay informed, and one in which the SUDEP risk is a bit higher. And the Child Neurology Foundation, for any practitioners who happen to be listening to this, also have a document which outlines what's called the SPIKE strategy, which is basically how to have a difficult conversation. And just because we're doctors doesn't mean we're any good at this. And so this actually gives some pointers on that. The most important thing about these conversations is people need to leave time. They need to leave time for questions, for supporting families, and for following up with questions afterwards. So I'm just going to conclude. I was asked to talk about how to talk about and what to talk about SUDEP, and this is what I think. I think they need to be face-to-face conversations with healthcare providers. They need to explain risk and how to modify that risk. They need to target the timing and the content of the conversation to the needs of the individual. We know parents want information sooner than adults living with epilepsy, so we need to consider that, and we need to give sufficient time and support. On that note, I'll stop.
Fantastic. That's really helpful overview. I learned several things in there, and I've been studying up on this. So thank you so much, Dr. Donner. So
I would like to stop sharing, but the little gone.
Well, Tom, if you start, I think it'll.
Oh, there it is. There we go. Thanks, Tom.
Yep. So Gabby, shall I jump in?
Please do.
Okay. Well, I just wanted to kind of reintroduce myself. I'm Tom Stanton from the Danny Did Foundation, which is a patient advocacy organization based in Chicago. And I just want to thank Gabby for giving us the opportunity to talk with you all today, or folks that may watch the recording. We believe really strongly that parents and caregivers are the kind of the catalyst behind a lot of change, positive change in terms of standard of care in the epilepsy community. So people like Gabby, people like Jill will move things forward. So it's important that we have the opportunity to talk like this. And I'm going to start just by sharing the story of my nephew Danny, and talk about how he passed from SUDEP. And then just kind of give an overview of some of the steps that we promote at Danny Did as far as what can we do, how can we take action. The focus of this webinar is really taking action. So I'll talk a little bit about the steps that we talk about. So this next slide shows Danny. He's in the light blue shirt here. He was an athletic and really affectionate little boy. He spent a lot of his time with his 3 siblings. So his older sister, Mary Grace, his older brother, John, and his younger brother, Tommy. And Danny had his first seizure around the age of 2. His parents, my brother Mike and his wife Marianne, witnessed about 4 seizures in the next 2.5 years. So he was fairly controlled by medication. He had no other medical complications. But just a few months before his 5th birthday, he went to the neurologist for kind of a routine checkup. His medication was adjusted for some weight gain, but they got a generally positive message. Similar to Jill's story, they were told they were on the right track, and they felt really hopeful that he would outgrow his seizures. And so that was on a Tuesday, and then 4 days later, on a Saturday morning, his mom, came in and found him in bed, and he had passed away. He was 4.5 years old, and the first time that they heard about the term SUDEP was from his death certificate. And the primary reason that they decided to start the Danny Did Foundation was just to kind of address the gaps that they experienced when they were treating Danny. And the work that we're doing. So as I said, when we started the foundation in 2010, we had 2 main points of focus. The number one was to just generally increase public awareness about epilepsy and the risks that come with it. In particular, the risk of sudden unexpected death in epilepsy. And to kind of tag on to Elizabeth's, Dr. Donner's discussion, we advocate for that honest and open dialogue to happen directly between doctors and caregivers, or doctors and adult patients. We just think it's so important to build that trust. And as everybody listening here knows very well, we as parents can and do digest difficult information all the time. And at the end of the day, it's our job as caretakers to consume that information and then to make a plan. And without the information, we're faced with a blind spot. Our second area of focus at Danny Did is to increase awareness about and access to devices and technologies that can alert to seizures. I won't spend too much time on this slide because Dr. Donner covered it very nicely. But as I mentioned, before my nephew died, his parents had never heard that term. And so, the lack of disclosure is unfortunately fairly common, but something that we're trying to change as advocates. And many in kind of the mainstream public first heard the term SUDEP last summer in 2019 when Cameron Boyce passed away. And we've since come to know that his parents had never heard the term SUDEP either. But so, part of our messaging is just, the biggest risk factors being uncontrolled seizure activity and regular tonic-clonic seizures. Just getting that accurate information out to the epilepsy community is really important. So again, some of this has been discussed, but just from the standpoint of Danny Did and the messages that we're trying to put out in kind of clear, simple ways, the number one message is that communication with your doctor is really essential. We can and do disclose the risk of sudden death with patients and adult caregivers on a regular basis. My colleague and I, Mary Duffy, have these conversations, but we always acknowledge and lead with the idea that this is best to occur with the patient, with the patient and the doctor directly. As I said, it just builds trust. And Dr. Guyard had mentioned the SUDEP guideline from a few years back, and then the position statement more recently, that encourages doctors to have this conversation. And historically, the belief was to have the conversation with the highest risk groups, or those who are perceived as the highest risk groups. But, in Danny's case, and in Quinn's case, and many others, that may or may not instigate the conversation. So we really advocate for it to happen across the board. But other steps that we talk about in terms of minimizing the SUDEP risk is really that idea of adherence, to motivate total adherence, whatever that entails for the family, be it medication or surgery or diet, just to be really disciplined about that. And that the information about the risk of SUDEP can be a motivator, certainly among certain age groups in particular, adolescents or high school, college age students. Having that information can really help to keep them as disciplined as possible with adherence. Just regular doctor's visits. I know all the folks listening today, that's probably a given, but just, for the community at large to really be on track, certainly if seizures are uncontrolled, to make those appointments regularly, ideally with a specialist, with an epileptologist, is really important. And then just considering alternative resources. And that's where, we think devices and technologies should be on the radar of parents and adult patients to complement a medication, diet, surgery, whatever the treatment plan may call for. So I'm going to talk a little bit more about those benefits as we see it. So I'll start with, the benefits to patients and caregivers. The reality is, and I think Dr. Guyard and Dr. Donner probably experience this regularly. Patients want them and they use them. So that's kind of a reality that we should start from. The idea of seizure tracking is a kind of a constant struggle for a lot of parents or adult patients to know exactly how many seizures are happening. And, that type of patient recall or caregiver recall is not always totally accurate. So having some kind of supplemental resource to count seizures and ultimately hopefully lead to more precise, medication treatments, and helping to educate what type of medication and what amount can be really helpful. The safety for the person who's experiencing the seizures is something that we talk about. Just the idea that intervention, we think, and we continue to learn can have some benefits. So the simple premise that if someone is present to do a well-being check, whether that means making sure the airway is clear, or the person hasn't fallen out of bed or had some other kind of accident, can lead to a better outcome. And then, as you all know, and kind of Gabby and Jill spoke to, is just the anxiety of coping with life with epilepsy. And so that reducing that on some level for caregivers definitely has value. And then, the idea of increased independence for patients, certainly of particular age groups, is a big benefit too, that these devices can contribute to. And then just some peace of mind, the ability to sleep knowing that there's this added layer of support, that you will be notified if there's a convulsive seizure, has its own benefits. I'm sure a lot of people listening know too well about these sleepless nights, and that can contribute to difficult days and that spiral, that cycle that's really difficult to maintain. We think it's important to talk about benefits to healthcare providers too. The devices can give the patient this kind of empowerment to be a part of their own treatment and to be actively engaged in their own care. There's the obvious benefit of timely interventions. If someone is having a seizure, I think most healthcare providers, all healthcare providers would acknowledge that it's better if someone is there. I alluded to just accurate data about the frequency of how often seizures are happening. And then the idea that those can lead to the more effective optimization of medications and hopefully, better control. There's discussion and thoughts along the idea that optimized medication will definitely reduce your risk of SUDEP by reducing the number of seizures that the person experiences. And then, we talk about just the idea of these devices contributing to research that can hopefully at some point pinpoint accurate biomarkers of what causes SUDEP and identify the people who are at highest risk. Another talking point that we want to be upfront about is just the idea that these devices are not a panacea, that they're not where they need to be. And I list here on this slide some of the shortcomings. There's always the balancing act of, the sensitivity. Are there too many false alarms? And does that lead to alarm fatigue? But, as we hear all the time, I think the standard among parents is maybe different than it is among some providers. And by that, I mean, for that one time that you're alerted to a seizure that's happening and you're able to intervene, it means a great deal to parents to be able to do that. So that's not to say that, we need to strive for more accurate devices as we move forward. And just, the usability, there's no one size fits all device right now. And so that there's a learning process of what are the options and what is a fit for my situation. And that's a lot of what we spend our time at Danny Did talking through with parents. So that kind of hits on this next slide, which is, how to determine what's the right fit. And so we do spend a lot of time, Mary and I, counseling patients and caregivers about what's available. How does it align with your needs for what you're looking to do? I think the first thing is to think through, does this system align with the seizure types that we experience? What are the goals for the device? Is it to be alerted? Is it to track how many seizures are happening? If you're looking to share information with your provider, how does the device do that? How secure is the sharing of data? Those sorts of things. Really simple, practical things like the comfort and age appropriateness of the device. So for example, if you've got a 2-year-old and you're thinking about a watch for him or her, probably not the most practical scenario. And so a lot of our work is just helping families have these slow down and have these practical considerations, in the midst of wanting something to work and being hopeful about trying the next thing that can help to ease some of their burden. It's really important that we as advocates have these conversations and make sure that the expectations are aligned as much as possible. So, I won't dwell too long on this slide, but I will say that, we spend a lot of time looking at what's in the pipeline and what's coming next. And we are hopeful by the number of and kind of the resources behind some of the systems that are in the pipeline. They're A lot of them are looking to learn over time and become more accurate over time. There are several that are being used in trials to understand the causes of SUDEP. And the FDA has become much more, I guess, accessible to a lot of these companies that are working on seizure detection devices, which has made it just a more fluid process. But ultimately, what we see kind of as the holy grail is a system that can alert to different types of devices. So not just movement-based devices, but devices that are multimodal that way, and then can predict a seizure and then deliver some type of intervention to suppress it. That is, we hope, in the future of this space. So I'll just spend a minute to say that, in addition to counseling families about what's available and what are the pros and cons, we do put a lot of our resources that Danny did towards helping families gain access. So, the basic process is to apply for a grant, and that application is on our website, which is dannydid.org. We talk with families live on the phone to kind of have a conversation about their expectations and their scenario. And then if we do fund a grant, it goes directly to the caregivers, and they purchase the system from the company that manufactures it. Excuse me, and we cover the cost. So there are other organizations which I list here that help in this realm, and unfortunately, there's a lot of demand, a lot of need. So every advocacy group that does this type of provides this type of resources is has plenty of families to interact with. So in closing, I just want to talk about something that Dr. Donner and I are very involved with, which is the Partners Against Mortality and Epilepsy. And this is a coalition of families, providers, advocates, researchers, industry partners who all come together to think about and talk about mortality and epilepsy. And obviously a big part of that discussion involves SUDEP, but it also talks about other causes of death, potential causes of death for people with epilepsy. So accidents and injuries, status epilepticus, the heightened risk for suicide. So we have a webinar coming up on December 7th that we invite everybody to be a part of. It's free. It takes place as part of the American Epilepsy Society annual meeting, which is virtual this year. The time and date are on the screen here, and you can learn more about registering at pamiionline.org. So we encourage everybody to check it out and hopefully to tune in so that you can learn more about PAMI and how to get involved. And that's my final slide. So I'll just kind of thank everybody again for giving us the chance to be a part of this.
Thank you so much, everybody. It's really a fantastic overview. And I think that this is going to be a great ongoing resource for folks to really better understand SUDEP and what we can do as of now. And our previous, the first webinar in the series, it was about kind of what do we know. And Dr. Sam Latu gave a really fantastic presentation kind of talking about, what exists, what's out there. Can you guys, and I'll leave this open to all of you to discuss, but he mentioned that we're kind of close to a SUDEP risk index for individualizing the susceptibility, and that we're learning a lot more about the process around breathing and cardiac dysfunction. Do any of you want to weigh in on kind of where we are with that and what we're looking for? And Tom, you did a little bit about kind of in terms of devices. Those are the things we're looking for is kind of detection and prevention.
Yeah, I mean, I think a lot more work needs to be done because we don't really know exactly what those risks are or what the mechanisms are. I think there's been a lot of very interesting information coming out of Jeff Noble's group looking at animal models of death and looking at mechanisms of death. But I mean, really, we need to know more data about risk factors. I mean, what we've been talking about mostly are those people with chronic, frequent nocturnal generalized tonic-clonic seizures who die in the 20s and 30s, but all the cases that have been presented today have been children with few seizures who should be low risk, who died. And, you know, we really need to know more about that population. That's really hard to identify. So, I mean, and Elizabeth will speak, but we need a lot more data to know what we're acting on and to make our devices work better.
Yeah, I agree. I agree with you, Bill. I don't think we're very close at the moment for an individualized risk assessment tool, because there's two flip, you know, we know that the frequency of generalized tonic-clonic seizures is very important as a risk factor, but two things. There are people without frequent generalized tonic-clonic seizures who die of SUDEP, and both Bill and I know lots and lots of patients with very frequent generalized tonic-clonic seizures who do not die of SUDEP. And so there's still a lot of questions about risk factors and how to tailor risk. And it's hard. It's not as rare as we wish it was, SUDEP, but it's rare enough that it makes it hard to study. And so we need to keep kind of hitting it from a variety of angles. And I think there's nice animal work going on. I think there's nice registry work through our North American SUDEP registry and others. And we're getting the information, but I don't think we're that close to having individualized risk stratification. But I do think that we can still focus on saving lives with the information we have now. Because just the fact that people don't know about it means that there's still room to make change.
Yeah, absolutely. Tom, did you have something you want to say? I saw you leaning.
No, I think Dr. Down is right. I mean, I think, you know, from this standpoint of we control the awareness level, the communication, we can improve that, you know, before we get to these benchmarks that, you know, we still need, biomarker benchmarks. We can improve the communication levels now, and that will have residual benefits, certainly for some of these cases.
Yeah. And one thing, I mean, this kind of leads us into, since there's so much we still have to learn about brain tissue donation. So Jill, that was something that was brought up with you in a very, very difficult time. And to try to make a decision at that point must have been, you know, absolutely heart-wrenching. But, you know, because I've been involved and I know about this stuff, you know, my son Elliot, who's almost 8, we signed him up for, you know, brain donation, you know, when he was 5, we had the paperwork ready, but that's not a decision that's easy to make in the moment.
We honestly, we would have done something like that. We had no idea. And it was too late by the time we found out about SUDEP and we contacted the North American SUDEP registry. It was days after. You're in a total fog. I'm sure that Tom can, or his brother and sister-in-law can relate to. It's total devastation and also shock, and you just kind of go through the motions. And had I known, and also we actually talked to the doctor about devices, and she's like, our doctor said they were counterintuitive, because I was like, should we have a device on her? And she goes, it will send out too many false positives, so that's counterintuitive. She won't get the sleep that she needs. But I mean, now we have a camera in case our other daughter has any seizures, which she is not. Thank goodness she had febrile seizures when she was younger. But we have the Sammy cam in case. And if we would have had that with Quinn, who knows? But she's like, oh no, don't get it. And I'm just, there's not enough information. So I can't stress enough. And like I said, I'm glad you were able to, and hopefully you never have to donate your son's brain tissue. I don't want that to ever happen, but
right.
It would have, had I known, we would have done something like that. We've donated her cord blood. We did donate her cord blood for research, because that's what we had left. And yeah,
Yeah.
But
Yeah, that's certainly something that hopefully is part of discussion as well. You know, when clinicians are having these discussions, that they present that as an opportunity, because that's the only way we'll learn, right? Is if we really can find out what happens. Dr. Donner, do you?
Well, the other piece some of us are working on, some of us that advocate in this field, is partnering with the death investigators. So those are like your pathologists, coroners, medical examiners. So the people that actually would be coming to the home or seeing a family, or having to be in contact with the family after someone dies. And by making those individuals aware of SUDEP, I think we have the opportunity to trigger some of those immediate research opportunities and help families to get information. So there's a lot of work underway working with medical examiners and death investigators. So I'm hopeful.
That's great. Yeah. And I know that as much as, you know, that SUDEP is really hard to track, that it even happens in hospitals, right? And it just, right? So it's something that's not even necessarily preventable when you're hooked up to many machines. And
yeah, it's so important, Jill, that you hear that message,
yeah.
that we know families that have lost a child when they've been in bed with them, when they've had a monitor on them. I have multiple stories of kids sleeping with their parents and dying of SUDEP. So we don't know enough about it to know. The data that suggests that someone going to someone after a seizure reduces SUDEP risk is probably true in some cases, but I know it's not true in all.
Yeah. Jill, do you have any questions that you want to present, or any feedback other than the messaging you've already shared? Okay.
sorry, I really don't. I just can't stress enough that if there are medical professionals out there, it's not your information to keep. You're supposed to educate everyone. That's your duty. As far as I'm concerned, as a physician, you're supposed to give us all the answers. You're not God. You don't get to pick and choose what we know. So, and because like I said, my daughter was at the lowest risk possible. And that's why no one talked about it with us. And she's not here.
Right.
And she's not the only person that died that day. I died. My husband died. My 5-year-old daughter, our life ceased to exist, and we started a new one. So.
Yeah, no, incredibly powerful. And I think that speaks to, I think that really speaks to the kind of the guidance and the position paper that AE has put out or around this, that this is something that should really be an opt-out, right? It's not something that, you know, providers should pick and choose. It's, you know, every family gets presented with this information, and they decide whether it's something they want to hear or not. Really appreciate your activism and leadership, Jill, in bringing this out, telling your story, sharing your experiences, and this is how we will change the world together, right? You're making a difference. And it's advocates like you, and Mike and Marianne and Tom and clinicians who get it, who will, like Dr. Donner and Dr. Guyert, who will help us ensure that this happens less and less, and we'll get there. So this is a really hard topic, and we're grateful to all of you for being here to discuss it with us and share with us. And you know, this will be an ongoing resource for the community, and we will of course post all of those resources that people in your presentations shared. We actually already have up a number of those resources on our that goes with the first webinar. Well, this one will be posted with as well. So with that, thank you everyone. Really so grateful that you were here. I quickly just want to share that here we go. So upcoming in November, we have a couple more webinars before the end of the year. And one of those is the third in this series on SUDEP, which is a caregiver panel, basically with parents sharing their experiences with prevention, trying to prevent, speaking with providers, prompting providers, losing children, and really helping those of us who were lucky enough to not have gone through that yet, hear and learn from those who have. We also have part 3 of our clinical trials, which is a caregiver panel sharing their experiences being engaged in clinical trials. And we just want to thank our sponsor for the SUDEP series, which was Neurocrine Biosciences, who helped us really have this come together. So thank you, everyone. Jill, thank you. And thanks to everybody for joining us, and we'll see you next time.
Thank you.
Gabby.
Thanks,
Thank
Gabby.
you so much for making this possible.
Thank you. Thank you for having me.
Bye.
Bye.